Thank you. And I guess we'll move on to sort of the next level of endovascular repair for aortic aneurysms and kind of where we're going as technology continues to change. I want to thank Venki and the organizers for the opportunity to present here. It's always great to come to Phoenix at this time of the year, especially from St. Louis. When I left, it was 3 degrees yesterday. These are my disclosures. Work with a few other companies, especially in the evaluation of many of these devices. So when we're talking about thoracoabdominal aneurysms, open repair still continues to be sort of the treatment of choice of well-selected patients that happen to be good operative candidates. And that may still be the best option for those patients, but there's clearly a growing population of patients that will benefit from other interventions. Over the decades, hybrid procedures have been developed for the management of these patients, combining open and endovascular techniques and devices to be able to complete a full thoracoabdominal repair in many of these patients. And full endovascular management for these patients have continued to grow, especially for those patients that are considered to be poor candidates from both a medical and a surgical standpoint. Chimneys and snorkels have been used over the years to manage some of these patients. ZFN devices were approved in the United States in 2012, now a little over a decade, and clearly techniques and technology have continued to improve. Physician-modified devices have been used more and more around the country to be able to manage some of these high-risk patients, and in selected institutions, they have the availability of custom manufactured devices to be able to treat these patients on an elective basis. But at this point, the TAMBE device was approved in the United States around a year ago for the management of patients with complex thoracoabdominal aneurysms and those patients with pararenal aneurysms as an off-the-shelf design that may be able to allow us to increase the ability to treat these patients with other devices that may fit them extremely well and be both off-the-shelf and readily available to most physicians. The devices I mentioned were approved in January of 2024 with a rollout a number of months later after the devices were sort of produced and the company was ready to be able to start selling these devices. There's ongoing physician training for the use of these devices, 1 day of didactic course, and physicians that have not had experience with the device require 2 proctor cases by the Gore Advanced EVAR team before they can broadly utilize these devices for their patient populations. Since this started, around 600 cases have been performed, and approximately 100 cases are being performed currently in a monthly basis, a number that continues to increase as more physicians are being trained. Around 100 physicians have been certified at this point for the use of the TAMBE device, in addition to the physicians that participated on the trial and had already done a good number of cases that did not require certification after the fact. But as you can imagine, the majority of the cases are still being performed by a relatively small number of physicians around the country, but I think this number is growing since the techniques and technology and abilities that physicians have gained really over the last decade will bring more physicians to be able to perform these procedures in a very successful fashion. So what's the design of the device? The TAMBE is a modular device consists with many other components that you already well know. Really the key component, that the unique component, is the 4-branch device or the aortic component with branch components, which for the trial was the VBX device, the original VBX device. At this point, the VBX device is available in the US market as a low-profile device, but the low-profile device was not part of the trial except for the last 10 patients in the trial. The device worked very well for this indication, and we're awaiting FDA approval for the low-profile VBX device to be used for this device as it's being used in the United States. The distal component is what most people know as the iliac branch device, the 23-millimeter bifurcated device, leg components which are standard, and aortic extension components which are also standard can be used with this device for the junction as a junctional component for these procedures. What about information from the trial? The trial had both a primary and a secondary arm. The primary arm was completed with 102 patients. The secondary arm, unfortunately, was not completed at the time of data lock, and it's still being enrolled. And hopefully, this patient population would clearly benefit from the use of these devices, but we're getting more data, and especially from the registry, we will probably get a lot more data about this. 102 patients were enrolled in the primary arm. The majority of them had thoracoabdominal aneurysms, around 60%, and 40% had pararenal aneurysms. The median procedure time was around 302 minutes with a blood loss of around 250 mLs. Procedures were done mostly percutaneous from a femoral region, and upper extremity access was close to being 50-50 from the right or the left arm, as the procedure requires both femoral and upper extremity access for its completion. As far as the discharge of these patients, the median stay in the hospital was 2 days in the intensive care unit and 4 days in the hospital. Obviously, that's significantly better than patients that undergo open thoracoabdominal repair, and around 89% of the subjects were discharged home after the performance of these procedures in the trial. There were 2 co-primary study endpoints, the first one being technical success and primary safety, and the second one clinical significant reintervention and lesion-related mortality were the endpoints that were looked at for this trial. For the primary endpoint, the performance goal was around 80%. 92% of the patients experienced freedom from procedural safety events, and unfortunately, the performance goal was not met, in particular because a number of unplanned placement of devices was done during the procedure to complete a successful treatment of that patient population. These included 9 aortic extenders to improve the overlap between components were used, and that was not expected. 6 additional patients had bare metal stents. An additional group of patients, 4 of them had thoracic extensions with a tag device, and a non-TAMBE component was also used. But the procedures were completed successfully, which obviously that's kind of the more important portion. If you look at this point how technical success is defined by the SVS standards, and you look at this trial compared to the technical success that the trial had of around 81% by its definition, the technical success rate by SVS standards was around 99%. There were a few patients that had endoleaks, only a few patients had aneurysm growth. An interesting fact is the branch occlusions at 1 year. There were 8 right renals and 6 left renal arteries that had a branch occlusion, something that's being followed very closely to see what's really the patency rates of these sort of downsloping branches in this patient population. Something that's going to be important as we compare it to other available devices. Only 5 subjects had aneurysm growth, and these were treated. 1 patient had a type 3 endoleak, and 4 subjects had type 2 endoleaks. 3 of those were treated appropriately with no further aneurysm growth. If you look at a subgroup analysis, when you look at patients that had thoracoabdominal versus pararenal aneurysms, interestingly, there was a higher percentage of patients with pararenal aneurysms that had increased aneurysm growth and total occlusion of the branches. And this may be related to the small space that you have when you have a pararenal aneurysm versus a thoracoabdominal aneurysm, something that we have to learn a little bit more as we follow these patients further and we start using the devices in our daily use and more physicians start using it. Very briefly, what are the steps to do this procedure? You need an arteriogram or a DynaCT to visualize the anatomy as you start. You need access from both the femoral and the upper extremities, 1 upper extremity, both femoral access. You get 5 wires through and through, 1 for the main device and 1 for each one of the portals to maintain access to each one of the portals. The device is advanced over the 5 wires and it's partially deployed. You cannulate sequentially each one of the branches before you open the device as a second stage. Deploy 3 of the branches and do not deploy the 4th branch just to avoid any of the potential movement of the device by the blood pressure. You want to open the full device and then place the 4th component. That finishes really the thoracoabdominal portion of the procedure. And at this point, all you have to do is a bifurcated portion of the procedure with the IBE device, just like you do on EVAR, a bifurcated component with 2 iliac limbs. You mold all the components in place, do a final angiogram with or without a DynaCT, and that will complete the procedure. The procedures in general take a few hours. As you get better over time, the procedures will be shorter. One thing that we've noticed at our center and at other centers that have had even a higher volume that you have since approval is a lot of the patients that were being treated with a number of other devices, with PMEGs or other devices, have decreased. The use of the TAMBE device has increased the ability to treat a broader number of patients and use fewer and fewer physician-modified devices in general. But we're looking at that in the long term further and further. One of the other things that's going to happen is now we're going to have thoracic taper devices that is going to be very helpful, something we didn't have in the trial, and that's why the second portion or the secondary arm of the trial was never completed. This should be available in the next few months for us to be able to treat more complex aneurysms. So in conclusion, thoracoabdominal aneurysm repair has clearly evolved over the last 15 years with increased utilization of endovascular techniques, and complete endovascular management is a growing option, at least in the United States, for the management of these patients. The TAMBE device is a great addition to what we have. It may reduce the use of some of these other devices, and a post-market registry is underway because we still have to learn a lot more of how and where these devices fit and if it's going to be ultimately an important tool in our endovascular toolbox. Thank you.
Thank you.